guys, welcome back to Agent Science into Practice. I'm Nicki.
And I'm Jess, and today we're diving into something that feels obvious once you see the data, but we don't often measure directly. We've got some really smart people with us today to look at their paper, Role of the Skilled Nursing Facility in Clostridioides difficile infection transitions of care.
Yeah, and we talk about preventing C. diff infection. You know, we talk about recurrence, we talk about incidence and prevention, we talk about antibiotics, and we should definitely be talking about all those things. But we don't always talk about what happens next, after a C. diff hospitalization and where patients go, especially when older adults leave the hospital. And today's paper looks squarely at that transition.
Right. Transitions of care where outcomes can either stabilize or unravel. So let's introduce our powerhouse group of guests. First, Dr. Cory Evans, Associate Professor at the University of Texas at Austin College of Pharmacy and Adjunct Associate Professor at UT Health San Antonio. Kelly earned both her PharmD and her PhD in translational science from UT Austin, which feels very appropriate because her research lives at that exact intersection. She focuses on prevention and treatment of CDI, the gut microbiome, and how we translate clinical research into real-world practice. She's published over 100 peer-reviewed papers and has secured more than $5 million in federal funding, which is fantastic feat, especially these days. So yes, she has been very busy. Kelly, welcome to the show.
Hello, everyone. Thanks for having me.
Yeah, and we are also joined by Glenn Tillotson. He's a partner at GST Micro and microbiologist consultant to the pharmaceutical and diagnostic industries. Glenn has more than 40 years of experience in infectious diseases across clinical research, commercialization, and scientific strategy. He's published over 230 articles, served on editorial boards, including The Lancet Infectious Diseases, and is currently editor-in-chief of Expert Review of Anti-Infective Therapy. He's also a fellow of IDSA in the American College of Chest Physicians. So Glenn, we are thrilled you're here.
Me too.
And rounding out the panel today, we have Cory Evans, the CEO of Clinware Solutions. Cory is leading AI-driven innovations in post-acute care, focusing on reimbursement optimization, documentation automation, EHR integration, and compliance. He's an occupational therapist by training, RAC-CT certified, and has led initiatives resulting in significant reductions in hospital readmissions in post-acute care settings. Welcome, Cory. We're excited to bring the operational and reimbursement lens to this discussion today.
Thank you. I'm certainly happy to be here and excited to talk with you all.
Fantastic.
Well, all right, guys, let's start with the headline. So this was a national cohort of more than 86,000 hospitalized older adults with index non-recurrent CDI or C. diff infection between 2019 and 2022. Only about 5% were admitted from a skilled nursing facility, or SNF, if you hear us say that, but nearly 30% were discharged to one. I think that is a striking asymmetry. So, Kelly, can you tell us, what does that tell us?
Yeah, absolutely. So, and just to give everybody a little bit of background, our team was fortunate to acquire data from the Premier Healthcare database, where we were able to acquire a nationally representative sample of C. diff infection patients. And this is an incredibly robust data source that represents patients from about a quarter of all hospitals in the United States. And one of the great things about it is it's longitudinal, so you're able to track patients between healthcare visits. And so some of the variables that we had access to included each patient's point of origin, so where did they come from when they were admitted to the hospital, but then also their discharge status, so where were they discharged to after they were hospitalized. And as you said, Nicki, in this C. diff population, we had a relatively small percentage of C. diff patients who were admitted from a skilled nursing facility, but nearly a third of C. diff patients were discharged to a SNF. And then even among those patients who were originally admitted to the hospital from their home, about a quarter ended up having to be discharged to a skilled nursing facility. And then we also found that discharge to another hospital or rehab facility or hospice was common. And so overall, I think these findings really highlight the debilitating nature of C. diff infection, and that these patients often need a higher level of care both during treatment and then following infection to help support treatment and recovery.
And so when we look at outcomes, patients admitted from the SNFs had a higher inpatient mortality, higher all-cause readmission, longer length of stay, and higher hospital costs. When we zoom out, is this primarily a CDI severity issue or potentially a frailty issue amplified by the CDI? Glenn, do you want to take that one?
Sure. It's a little bit of a chicken and egg situation here. I think frailty, that's a good word that you've picked on. In fact, over the last few years, there have been 3 really interesting studies that have looked at frailty from different perspectives. Patients who are frail are more inclined to get C. diff, but when they have C. diff, they become more frail. So it's a bit of a chicken and egg. And different ways of measuring the frailty. There's a group out of Italy used the multidimensional prognostic index as one way of measuring the frailty and the poor health of these patients. Then, and my colleague Dr. Reveles actually used the VA frailty index to measure the susceptibility of these patients to disease. And in fact, dare I say, Kelly's group showed that amongst frailty, weight loss, anemia, those are drivers of actually contracting C. diff. But I think one thing to understand about the older patient is that they suffer what's called immunosenescence. So their immune system, as you get older, becomes less and less capable of fighting infection. So that contributes to the overall frailty. So the frailty in of itself drives you to be more susceptible to C. diff. But then when you develop C. diff, your weight loss, your anemia, and general overall body strength diminishes as well. And that may open the door for what we call recurrent C. diff infections, which is an entirely different story. So hopefully that's answered the question for you.
Yeah, that's great. Thank you.
Yeah, and one of the strongest predictors of both SNF origin and SNF discharge was dementia. So how should that reshape how we think about CDI risk stratification in older adults? Kelly, I'm going to lob that back to you.
Yeah, and I think there are several pieces of this story, and it's actually a great jumping off place from what Glenn was just talking about with frailty. So, first, we know that dementia itself is the leading cause of patients having to be admitted to a skilled nursing facility, and that's primarily related to the loss of functional independence that often comes with dementia. But there's also this bidirectional relationship between C. diff and dementia. So patients who have dementia may be more predisposed to C. diff infection in the first place due to underlying frailty, like Glenn suggested, but also healthcare exposures, like more hospitalizations, and then also medications that increase C. diff risk, like antibiotics, gastric acid suppressants, and oftentimes these patients require enteral feedings, which can also increase C. diff risk. And then there's even some evidence that dementia is associated with changes in the gut microbiome, specifically a reduction in microbial diversity or some of our generally healthy microbes. And so this may promote colonization and infection with C. diff. And then on the other hand, C. diff may actually accelerate cognitive decline due to just the severe inflammation that patients get with this infection that can disrupt not only the gut microbiome, but even inflammation in the brain. And then lastly, we know that patients who develop C. diff who have underlying dementia are at higher risk for poor C. diff health outcomes like mortality, recurrence, longer hospital stays. And this is likely due to exacerbation of the underlying conditions, but also acute delirium, frailty, and malnutrition. So I think we probably need to consider dementia not only as a risk factor for skilled nursing facility admission, but also C. diff as well.
That's super interesting, especially the piece about the microbiome. It's just like it's we hear a lot of research going on around microbiome and like how it affects like other, parts of your body or illnesses. So that's a really interesting point. I'm hoping that we can hear more about that in future research. So the readmission data is also fascinating as well. In the CDI readmissions were around 12% across all groups, but all-cause readmissions were higher in SNF patients. So from a post-acute perspective, Cory, and operational lens, what is that really telling us?
Yeah, Jess, it kind of piggybacks a little bit off of what Glenn spoke about before with CDI, the chicken and the egg theory. And I think what's interesting from a skilled nursing perspective is, we're receiving the patient that typically their primary diagnosis driver is CDI. And when you analyze those figures, it becomes actually pretty clear that the primary diagnosis like CDI is actually not the primary driver for readmission. Typically the infection itself rarely is what triggers a return trip to the hospital, but rather it's the secondary system failures like an acute kidney injury or congestive heart failure that are really pushing the patient over the edge by the physiological strain on the illness. So this data really reveals that while we've mastered the CDI protocol, we haven't really yet mastered the holistic clinical monitoring required to keep a complex patient stable, especially fragile patients that require the skilled nursing level of care.
It's very interesting.
So infectious diagnoses, especially septicemia, were the most common principal diagnosis on readmission. So it's not just reoccurrence, it is destabilizing patients. So is CDI a tipping point in already vulnerable patients? Glenn, can I lob that to you?
You can indeed, Nicki. Okay, Kelly just touched on it about the microbiome and its protective influence. One of the problems with CDI is that it occurs because of what we call dysbiosis, which is disruption of the normal healthy microbiome. The healthy microbiome has got lots of different bacteria in the right proportions. And when you disturb those proportions, you disturb the holistic environment, which goes to Cory's point. And the good bugs in your bowel protect you from a variety of different things. They prevent inflammation. They maintain the integrity of the bowel wall. If you bring bad bugs in there, they allow the bad bugs to take over. Then the integrity of the bowel wall becomes porous. And the bad bugs in your bowel then get into the bloodstream, and it leads to septicemia. And in fact, some recent work by Paul Feuerstadt's group out of Yale showed that of the various reasons for being readmitted, 3 of the top 10 were sepsis or septicemia. And Cory mentioned acute kidney injury was, I think, number 6 on that list. So the good bacteria prevent you getting these sort of complications. If you disrupt the microbial flora, the microbiome, then you will get a porous bowel leading to this invasion. But also you get disruption in a whole host of other metabolic processes, which can affect liver function, kidney function, and even diabetes. So good bugs are important.
Yeah, for sure. Can I ask a quick follow-up question on that? Just something that recently had come to mind, and this is the perfect, I think, venue to see if maybe you know the answer to this. But does the level of disruption of the normal bowel flora, does toxin production of the Clostridioides impact the level of disruption of that flora?
Yes.
Solid answer. Thank you. I was just wondering about that recently because we were talking about another specific organism, and I was like, I wonder if toxin production would have an effect on the growth of other organisms within that particular space. So I just thought that was an interesting follow-up.
Can I carry the sidebar then? What happens is that your bad bugs lead to this disruption, and that disruption is then exploited further by the toxins produced by C. diff. And you get into a vicious cycle then of the toxin making the bowel leakier, also affecting other functions of the microbes in the bowel. So you get into this you'll see my favorite thing in life. It's everything is biological. It goes around in circles. And I think here we need to realize that once the environment changes sufficient to make Clostridioides sporulate and then also produce toxins, then the horse is out of the stable. The damage is done and will continue to be done until we stop that process.
Awesome. Thank you. That was great. That definitely was
As
helpful.
a Kentuckian, I approve of your equestrian nod.
So the study also found that oral vancomycin was a predictor of SNF discharge. Is that simply continuation of therapy, or does this reflect access limitation to fidaxomicin in long-term care settings? Kelly, do you want to take that one?
Yeah, absolutely. So, a short story, I think it's likely both. And just to give a bit of background, so fidaxomicin and vancomycin are both our workhorse antibiotics for C. diff. And vancomycin in C. diff is kind of unique in that we give it orally, so by mouth, and that's compared to just about every other infection where we give it intravenously. And we do this so we can get high concentrations of the vancomycin in the gut to adequately kill C. diff. And then fidaxomicin is dosed similarly, where we give it by mouth to reach high concentrations in the gut to kill C. diff. Now, both of these antibiotics are really effective at killing the active infection with C. diff, but there's actually a pretty big difference in how they affect other bacteria in our GI tract. So fidaxomicin is what we call a narrow spectrum antibiotic, which means has very targeted killing of C. diff while sparing most other good bacteria in the gut, which, Glenn just mentioned are very, very important for not only protecting against future C. diff infections, but also just maintaining other general health. Now, vancomycin, on the other hand, is quite broad spectrum. So it's going to kill C. diff, but it's also going to kill a lot of the other good bacteria that we have in our gut. So what we've seen in clinical trials is these agents are essentially equally effective in curing infection, but we see much lower rates of C. diff recurrence with fidaxomicin compared to vancomycin. And so the most recent guidelines that we have, clinical practice guidelines for C. diff, do favor fidaxomicin for this reason. Now, that being said, fidaxomicin is quite a bit more expensive than oral vancomycin, and so that's historically limited its use. And we actually have a prior published study on this using the PharmD database, where we found that vancomycin is the most common antibiotic used to treat C. diff in the U.S. in this national sample. And so our finding in the current study likely reflects a continuation from using vancomycin in the inpatient setting, but then also the cost prohibitive nature of fidaxomicin in the outpatient or long-term care setting.
Well, let's talk about cost. Let's talk about the reality of reimbursement. Short-term SNF stays are reimbursed under fixed daily rates, and that has to cover everything. So that has to cover medications, therapy, staffing, infection control, etc., everything. So how does that structure influence antibiotic selection or discharge planning decisions?
Yeah, that's a great segue, Nicki. It certainly dovetails nicely off of what Kelly had just spoken about in regards to the pricing, especially for these high-cost antibiotics. And certainly there's some complexity here when, the fixed daily rate structure within the skilled nursing facilities, we are reimbursed in this manner. And what it does is it creates actually a significant clinical hurdle, because many of the advanced, high cost antibiotics are actually bundled into consolidated billing, which effectively means that the skilled nursing facility often absorbs the costs at a net loss. And so, while Medicare, provides specific exclusions for certain high cost services, medical innovation is actually moving far faster than legislation can keep up. And what that's effectively doing is leaving a significant gap between modern clinical standards and reimbursement reality. So operationally, this really forces a difficult tension and risk to the provider that actually ends up, in a financial bind in order to effectively manage the patient's illness.
And so when we talk about managing and preventing recurrence, how realistic is it in a post-acute setting?
I think the message I would say is really stick to the basics of good clinical practice. That's not to malign our colleagues, but I think the most important thing for me is to make sure that you use antibiotics only in the patients that really need them. 70% of patients in nursing home systems are on an antibiotic or have received an antibiotic in the prior 3 months. So that has really done significant damage to their protective bowel flora. And that is something that needs to be considered, that, don't just give antibiotics because Mrs. Jones has got a bit of temperature. You need to have a good reason for giving an antibiotic. In addition to damaging the patient specifically, you also can drive antibiotic resistance. And in the nursing home system, those bacteria can travel around pretty darn quickly. So there's 2 reasons for using antibiotics wisely. Another drug class that's used extensively are proton pump inhibitors. Try to only use those in patients that genuinely need PPIs. Again, the PPIs have an adverse effect on the microbiome. And I keep going on about the microbiome being so protective. It's vital. It's probably a major organ in our body, and it needs to be nurtured. And if you want to nurture this, once someone has had CDI, then a good way to do it is to try to replace the bad bowel that you've developed with a good bowel and a good bowel flora. You can do that using what's called a fecal transplant. And there's a variety of ways of doing that. Well, that's a very good way of breaking that cycle of repeated disease and repeated infections. So good practice with antibiotics and PPIs, and look to ways to restore the protected bowel flora.
Yeah, so throughout this discussion, we have sort of highlighted that antimicrobial stewardship in nursing homes is potentially critical, and even enhanced barrier precautions, drawing parallels to MDRO prevention strategies in acute care. And as Glenn, as you were just talking, that was what immediately came to mind, is like that Nicki and I have talked with other authors about enhanced barrier precautions in SNFs and how things are done slightly differently just because of the population and the difference between the acute care and SNF operations. Kelly, where do you see the biggest prevention opportunities in SNFs around these types of things?
Mm-hmm. Yeah, I think there's many, because there's so many shared drivers of not only C. diff infections, but infections with multi-drug resistant organisms that are really common in skilled nursing facilities. And as Glenn alluded to, antibiotic use is one of the biggest drivers. But also, among SNF patients, there's often these frequent hospitalization SNF transitions. So patients may be bringing bugs back to their respective facilities. And then, of course, we have the population who's already at risk with, older age and frailty. And then in the SNF environment, certainly, high touch environments where organisms can be transmitted between patients, providers, equipment, et cetera. And of course, as an infectious diseases pharmacist, antibiotic stewardship is one of my absolute passions. And antibiotic exposure is arguably the strongest modifiable risk factor for both types of infections. So certainly we do need to limit antibiotics to only those true infections. And then among patients who actually have confirmed bacterial infections, optimizing the treatment so patients can have those treated effectively. So, I think, along those lines, some of the approaches that we really need: for one, improved diagnostic accuracy before starting therapy, avoiding antibiotic treatment in our patients who don't need it. So one of the classics, I think, in long-term care facilities is, patients have bacteria in the urine, but they are completely asymptomatic. We don't treat that. You don't need to treat that. And then other things, avoiding high-risk antibiotics like fluoroquinolones, and then shortening antibiotic durations to the minimum needed to truly treat the infection. So I would say in an ideal world, every facility would have access to a stewardship-trained clinician, and that stewardship would be embedded within the facility workflow so that antimicrobial use can be not only monitor, but manage more effectively. And then you alluded to barrier precautions. Certainly preventing transmission between patients is critical. So hand hygiene, and with C. diff, we know we need soap and water because alcohol-based rubs are not helpful. But of course, including contact precautions and using dedicated equipment and environmental cleaning when you can. And then I would say last but not least, is certainly an opportunity is just better interfacility communication between hospitals, clinics, the skilled nursing facility. So if we have a patient's history where we know either they're colonized with a potential pathogen or they have a recent C. diff infection or recent antibiotics, that can go a long way in identifying patients who are most likely to develop these infections so they can be monitored more aggressively.
Yeah, it's definitely a challenge. One challenge that we've experienced is that, oftentimes the skilled nursing facilities don't want to take these patients that are known to have CDI or other MDROs or have a recent history. Yeah.
That throughput is difficult. And there is some CDC changes about hand hygiene, which I want to get your all's opinion. I know there is some guidance out there from the CDC that says you don't have to use soap and water. You can use alcohol hand rub. You can use alcohol hand rub unless you're in middle of an outbreak. Then you should use soap and water, which I think is confusing. So I'm not sure exactly where we're landing these days on hand hygiene and C. diff. Do you all have any?
Yeah, I mean, I would say it's still best practice, at least, if you have a patient that's known colonized or actively infected with C. diff, you need to use soap that will kill the spores, because the alcohol-based rubs themselves won't actually kill C. diff spores. And those are,
the friction to get them off, yeah.
Yeah.
But it's a conversation that's starting to circulate in the infection control community that there may be some expected changes around hand hygiene and C. diff that I am nervous about. Sounds like you are too. And we'll see where it goes. We'll see where that guidance takes us. So for listeners who might not work directly in post-acute care, why do so many older adults who get C. diff end up needing skilled nursing afterwards? Glenn, can you shed some light on that?
Sure. I think one of the problems we've mentioned is that C. diff patients become more frail. They're probably frail to start with, but they become more frail. And one of the observations from the UVA crew with Shirley Warren is the degree of cognition that really tails off quite quickly in these patients. Confusion, inability to function even half normally. So I think those patients need expert care. They need the facilities from the SNF. And I think that's due to and I think Kelly touched on it earlier, the imbalance in the gut causes these disturbances in the gut-brain axis. And if you've not got the right metabolites improving your brain function, then it goes back to this increased frailty, increased poor cognition. And many of them, by being frail, are also perhaps unstable and not very good at getting around. And the level of self-care is also affected. So I think it's important that people really appreciate that. Actually, brief digression, a friend of mine basically said, patients who've had recurrent C. diff have PTSD. And that is a really profound observation. Older patients especially, they will have significant stress related to the disease. They're frightened of giving the disease to family members. They're concerned about going out. So if you have patients who have PTSD related to C. diff, concerted care facility is exactly what they need.
Wow, that is a really interesting point. Something certainly to think about in the future. Another question for Cory around SNFs. If you could implement one system level intervention tomorrow that you think would be the most meaningful to reduce downstream CDI burden at SNFs, what would that be?
That's a great question. considering I have the option for one, I would probably say, if we're looking at like the most impact, right? As you're pertaining to the system level intervention, it certainly becomes like a multi-pronged approach in really using, tech-enabled clinical strategy that integrates, AI-driven risk stratification. And basically what that can allow us to do is essentially, improve with robust medication reconciliation and create a bridge, right, to gap between like the acute and post-acute. And so, from a clinical perspective, utilizing AI to actually identify high-risk candidates for secondary system failures actually allows, for a clinical transition from reactive infection control to more proactive comorbidity management before, a stress test like a CDI causes a crash. And so, if we're looking at like a one system level intervention, by really layering an AI driven clinical pathways, we can actually better manage the patient within the nursing home, really ensuring that the diagnostic specific protocols are balanced with more of that holistic approach to monitoring that patient.
And Dr. Reveles, does C. diff permanently alter someone's health trajectory? Or can patients return to baseline with the right support?
Yeah, so, I would say C. diff infection can permanently alter a patient's health trajectory in some cases, but many patients can return to baseline, especially with effective treatment, microbiome recovery, which is super important, but also supportive care. But the outcome really depends heavily on a lot of factors. So the patient's age, their kind of baseline health and frailty status, the severity of the C. diff infection, and then C. diff recurrence. So I would say those who are most likely to fully recover are going to be the younger, a little bit healthier patients who have a mild to moderate infection at baseline. However, those who present with severe C. diff or those who are older or more frail, so our SNF residents, right, are more likely to have this stepwise decline in health and functional status following C. diff. And I would say arguably the biggest driver of decline is recurrent infections. So we know from prior literature, a quarter up to 35% of C. diff patients will experience a first recurrence. And then of those patients, up to 65% will experience multiple recurrences. So you can imagine with these repeated episodes, patients not only have this progressive microbiome depletion, but also more antibiotic exposure, more risk for hospitalization and general functional decline. And so this is one of the big reasons that much of our focus in not only the clinical space, but also on the research side is preventing recurrences with our preferred antibiotics like fidaxomicin and our newer therapies that can help replenish the gut microbiome. Like Glenn talked about fecal transplant, and then we have some newer FDA-approved therapies that can also replenish the microbiome.
I'm pondering like this entire conversation because there's so many points that you have all given that are just so interesting. I'm just like, this is been such an awesome conversation.
I know. I thought I knew everything there was to know about C. diff.
Yeah, it's making me think about all these things that are brought up, like the PST and like the thinking about managing comorbidities to help prevent it, be more on the preventative instead of the reactive side. So it's just very interesting. So I really appreciate this conversation today. But and one more question for Cory. What should hospitals be communicating to SNFs at discharge to reduce recurrence and complications? And I think, Kelly, maybe you've touched on this a little bit too, but just curious what your thoughts are on like the communication piece.
Yeah, certainly, Jess. And I think, being a provider in skilled nursing facilities for 25 years, starting as a clinician where I was receiving these discharge packets to overseeing multiple facilities, looking at operations and compliance and making sure we're meeting clinical capabilities. What I really discovered during that process is that, when it comes to reducing reoccurrence and complications, whether it's CDI or any other condition, data interoperability is really king. And so what that means is hospitals really need to move beyond just simply communicating through a discharge referral system, and instead really provide more of a transparent, longitudinal view of the patient's clinical journey. Specifically their full antibiotic exposure history, which we've mentioned earlier, really truly understanding, when it relates to even acute kidney injury, what is the baseline renal and even cardiac lab values? And what are the detailed comorbidity mapping? Those things are critically important to understand the downstream effect of those secondary conditions, and sometimes just surfacing the fact that somebody has a CDI and what the treatment was in those 3 or 4 days in the hospital are valuable information, but there's even just as much value, if not more, understanding the full mapping of that patient's clinical comorbidities that could exist that even occurred maybe a month ago. And so without this, seamless data exchange, really nursing homes are forced to manage these high-risk patients kind of in a vacuum, often missing the subtle physiological cues that could actually precede a secondary system failure, such as what we've mentioned before, acute kidney injury or congestive heart failure. So essentially, establishing a critical interoperability flow from the hospital's EMR to the post-acute EHR, the electronic health record, is really essential for ensuring that the high-resolution data is actionable on day one, allowing the skilled nursing facilities to implement precise clinical pathways and medication reconciliation that prevents those costly readmissions.
It's a holistic approach, and I think what I appreciate about the study is that it forces us to look at frailty and cognition and transitions and reimbursement models, real world consequences of a diagnosis, when we often contain that to an acute hospital stay.
Right. And when nearly 1 in 3 hospitalized older patients with CDI required skilled nursing care afterward, prevention and optimized early therapy are more than clinical decisions. They're system and continuum of care decisions. So again, such an awesome conversation. I think Nicki and I both learned a lot today and have a lot of things to think about, and hoping to see more research in the future about this. But a huge thank you to Kelly, Glenn, and Cory for helping us unpack your article and research on CDI care. And we look forward, hopefully, to having further conversations with you in the future. And also thank you to our listeners for joining us on AJIC Science into Practice.
And remember, C. diff does not always end in discharge. Sometimes it just changes addresses. And guys, that's a wrap.
Thank you for joining us today. We are Nicki Shore and Jessie Swain, and this is the American Journal of Infection Control podcast, Science into Practice. Thanks for listening and doing your part to prevent infection, because remember, infection prevention is everybody's business.
AJIC Science into Practice is created by the Association for Professionals in Infection Control and Epidemiology with input from the APIC Center of Research, Practice, and Innovation, and Jean Brandt at AJIC and APIC staff, Rebecca Bartles, Ria Gupta, and Bobby Gulshan. We work in partnership with Human Factor and audio techs Blake Alton and Carolyn Schneer. To hear other AJIC episodes and to access information about this podcast and the field of infection prevention and control, go to our website, ajicscienceintopractice.org. That's AJIC scienceintopractice.org.